According to the American Heart Association, many commonly used medications from a wide array of drug classes may cause or worsen a variety of arrhythmias. Proarrhythmia is the ability of a drug to cause an arrhythmia, the number one reason for drugs to be withdrawn from the patient. Drug-induced arrhythmias are defined as the production of de novo arrhythmias or aggravation of existing arrhythmias as a result of previous or concomitant pharmacologic treatment. In this video, we'll look at drug-induced cardiac arrhythmias with a focus on QT prolongation and torsades de pointes. The information presented in this video should not be used for diagnosing or treating a health problem. Consult your healthcare provider before making any changes to your health plan. Remember to subscribe to this channel so you can be notified of more pharmacy and medicine-related videos. In a typical heartbeat, a tiny cluster of cells at the sinus node sends out electrical signals called impulses. The signals go through the upper heart chambers to the atrioventricular or AV node. Next, the signals pass into the lower heart chambers called the ventricles. This causes the heart to squeeze, which pumps blood throughout the body. However, in a cardiac arrhythmia, which is an irregular heartbeat, a heart arrhythmia occurs when the electrical signals that tell the heart to beat don't work properly. The heart may beat too fast or too slow, or the pattern of the heartbeat may be inconsistent. A heart arrhythmia may feel like a fluttering, pounding, or racing heartbeat. Some heart arrhythmias are harmless, however others may cause life-threatening symptoms. Many widely used medications may cause or exacerbate a variety of arrhythmias. Numerous antiarrhythmic agents, antimicrobial drugs, psychotropic medications, as well as methadone, and a growing list of drugs from other therapeutic classes including neurological drugs, anticancer agents, and others, can prolong the QT interval and provoke torsades de pointes. Perhaps less familiar to clinicians is the fact that drugs can also trigger other arrhythmias including bradyarrhythmias, atrial fibrillation or atrial flutter, atrial tachycardia, atrioventricular nodal reentrant tachycardia, monomorphic ventricular tachycardia, Brugada syndrome. Some drug-induced arrhythmias, such as bradyarrhythmias, atrial tachycardia, atrioventricular node reentrant tachycardia, are significant predominantly because of their symptoms. However, others, such as the monomorphic ventricular tachycardia, Brugada syndrome, Torsades de pointes, may result in serious consequences, including sudden cardiac death. Mechanisms of arrhythmias are well known for some medications, but in other instances remain poorly understood. For some drug-induced arrhythmias, particularly torsades de pointes, risk factors are well defined. Modification of risk factors when possible is important for prevention and risk reduction. In patients with non-modifiable risk factors who require a potentially arrhythmia-inducing drug, enhanced electrocardiographic and other monitoring strategies may be beneficial for early detection and treatment. Management of drug-induced arrhythmias include discontinuation of the offending medication and following treatment guidelines for the specific arrhythmia. In overdose situations, targeted detoxification strategies may be needed. Awareness of drugs that may cause arrhythmias and knowledge of distinct arrhythmias that may be drug-induced are essential for clinicians. Consideration of the possibility that a patient's arrhythmia could be drug-induced is important. Now let's talk about QT prolongation. QT prolongation is a measure of delayed ventricular repolarization, which means the heart muscle takes longer than normal to recharge between beats. It is an electrical disturbance which can be seen on an electrocardiogram or EKG Excessive QT prolongation can trigger tachycardias, such as torsade de pointe, or TDP. QT prolongation is an established adverse effect of antiarrhythmics, but can also be caused by a wide range of non-cardiac medicines such as antibiotics, antidepressants, antihistamines, opioids, and complementary medicines. On an EKG, the QT interval represents the summation of action potentials in cardiac muscle cells, which can be caused by an increase in inward current through sodium or calcium channels, or a decrease in outward current through potassium channels. By binding to and inhibiting the rapid delayed rectifier potassium current protein, certain drugs are able to decrease the outward flow of potassium ions and extend the length of phase 3 myocardial repolarization, resulting in QT prolongation. A QT interval is a value that is measured on an electrocardiogram. Measurements begin from the start of the Q wave to the end of the T wave. The value is an indication of the time it takes for a ventricle from the beginning of a contraction to the end of relaxation. The value for a normal QT interval is similar in males and females from birth up to adolescence. During infancy, a normal QT corrected range is defined as 400 plus or minus 20 milliseconds. Before puberty, the 99th percentile of corrected QT values is 460 milliseconds. After puberty, this value increases to 470 milliseconds in males and 480 in females. In the diagram on this slide, on the right side you see a normal QT length, but on the right side you can see a prolonged QT length on the EKG, and this is how you would be able to tell that there is a QT prolongation. Some more info on QT prolongation. Unfortunately, there is no absolute definition that describes the incidence of drug-induced QT prolongation, as most data is obtained from case reports or small observational studies. Although QT interval prolongation is one of the most common reasons for drug withdrawal from the market, the overall incidence of drug-induced QT prolongation is difficult to estimate. One study in France estimated that between 5 and 7% of reports of ventricular tachycardia, ventricular fibrillation, or sudden cardiac death were in fact due to drug-induced QT prolongation and torsade de pointe. An observational study from Netherlands showed that 3.1% of patients who experienced sudden cardiac death were also using a QT prolonging drug. Although it is difficult to predict which individuals will be affected from drug-induced long QT syndrome, there are general risk factors that can be associated with the use of certain medications. Generally, as a dose of a drug increases, the risk of QT prolongation increases as well. In addition, factors such as rapid infusion, concurrent use of more than one drug known to cause QT prolongation, diuretic treatment, electrolyte imbalances such as hypokalemia, hypomagnesemia, hypocalcemia, advanced age, bradycardias, females have all been shown to be risk factors for developing drug-induced QT prolongation. TDP has been shown to occur up to 3 times more often in female in comparison to males, likely as a result of post-pubertal hormonal influence on cardiac ion channels. The QT interval is longer in females, as well as having a stronger response to inward rectifier potassium channel or IKR blocking agents. In males, the presence of testosterone upregulates IKR channels and therefore decreases the QT interval. Stated otherwise, estrogens prolong the QT interval, while androgens shorten it and decrease the response to IKR blocking agents. Structural heart disease, such as heart failure, myocardial infarction, and left ventricular hypertrophy are also risk factors. Diuretic-induced hypokalemia and/or hypomagnesemia taken for heart failure can induce proarrhythmias. The ischemia that results from myocardial infarctions also induces QT prolongation. On an EKG, the QT interval represents a summation of action potentials in cardiac muscle cells. QT prolongation therefore results from action potential prolongation, which can be caused by an increase in inward current, sodium or calcium channels, or a decrease in outward current through potassium channels. By binding and inhibiting the rapid delayed rectifier potassium current protein IKR, which is encoded by the hERG gene, certain drugs are able to decrease the outward flow of potassium ions and extend the length of phase 3 myocardial repolarization, which is reflected as QT prolongation. Most patients with drug-induced QT prolongation are asymptomatic and are diagnosed solely by EKG in association with a history of using medications known to cause QT prolongation. A minority of patients are symptomatic and typically present with one or more signs of arrhythmia, such as lightheadedness, syncope, or palpitations. If the arrhythmia persists, patients may experience sudden cardiac death. To manage QT prolongation, first remove the causative agent or the drug or drugs that are causing the QT prolongation. Correct any electrolyte abnormalities. In severe situations, cardioversion or defibrillation may be required, particularly in hemodynamically unstable patients. IV magnesium is also useful for the treatment or prevention of torsade de pointe. Now let's focus on torsade de pointe, also called TDP or simply torsade. TDP is a polymorphic VT, ventricular tachycardia, associated with QT prolongation. Torsade may be inherited, for example, congenital long QT syndrome, or acquired, of which the most common cause is medications. Drugs including terfenadine, estomizole, grepafloxacin, cisapride, and levomethodil have been withdrawn from the market in the United States and other global markets as a result of torsade-associated death. However, more than 200 drugs remain available with the potential to induce torsade. The incidence of torsade in the general population is unknown, but has been reported to range from 2.5 to 4 per 1 million person years in men and women, respectively, to as high as 4 per 100,000 individuals annually. The incidence of torsade among patients in adult intensive care or progressive care units over a 2-month period was 0.07%. 6% of cardiac arrests were caused by torsades. Drugs cause torsades primarily through inhibition of the rapid component of the delayed rectifier potassium current, or IKR, resulting in action potential duration, prolongation, and increasing susceptibility to early after depolarizations. Some drugs, including dofetilide, ibutylide, sotalol, thioridazine, and erythromycin, also prolong ventricular action potential duration in part through augmentation of late sodium current. For some of these agents, this is due to the effects of the phosphoinositide 3 kinase pathway. Although torsade is often transient, self-limiting, and spontaneously terminating, it can degenerate into ventricular fibrillation and cause sudden cardiac death. Some drugs, including typical and atypical antipsychotic agents and fluoroquinolone and macrolide antibiotics, have been associated with an increased risk of sudden cardiac death or cardiovascular death, potentially caused by torsade. Drug-induced torsade is rare in patients without risk factors, which include heart rate corrected QT interval greater than 500 milliseconds, or corrected QT lengthening greater than 60 milliseconds from pretreatment value, female sex, age greater than 65, bradycardia, acute myocardial infarction, hypokalemia, hypomagnesemia, hypocalcemia, heart rate with reduced ejection fraction, concomitant administration of greater than or equal to 2 QT prolonging drugs, history of drug-induced torsade, and conditions leading to elevated plasma concentrations of QT prolonging drugs such as pharmacokinetic drug-drug interactions, rapid intravenous administration, and inadequate dose adjustment of renally eliminated or hepatically metabolized QT prolonging drugs in patients with kidney or liver disease, respectively. These can all increase the risk of experiencing torsades. Some patients who experience drug-induced torsade may have a genetic predisposition. Nearly 30% of patients who develop drug-induced QT prolongation carry mutations for one of the 5 major long QT syndrome genes. And QT prolongation can become unmasked when these patients receive a QT lengthening drug. In addition, common genetic variants in aggregate may increase the risk, and a polygenic risk score has been shown to predict drug-induced torsade. However, general genetic screening for prediction of drug-induced torsade is not currently recommended. The potential for drug-induced torsade may be reduced by correcting modifiable risk factors. For example, in patients taking QT prolonging drugs, serum potassium and magnesium should be maintained at greater than 4 milliequivalents per liter or 2 milligram per deciliter, respectively. Concomitant administration of QT prolonging medications with drugs that inhibit their metabolism should be avoided. Doses of renally eliminated and hepatically metabolized QT prolonging drugs should be adequately adjusted in patients with kidney or liver disease respectively. Management of drug-induced torsade is dependent on distinguishing the arrhythmia from the monomorphic ventricular tachycardia, non-torsade polymorphic ventricular tachycardia, or short-coupled ventricular tachycardia. QT prolonging drugs should be discontinued, and hypokalemia, hypomagnesemia, hypocalcemia should be corrected as part of electrolyte abnormality correction. Patients with hemodynamically unstable torsade should undergo defibrillation or cardioversion because shock synchronization may be impossible in patients with polymorphic ventricular tachycardia. Intravenous magnesium of 1 to 2 grams repeatedly if necessary may terminate hemodynamically stable torsade regardless of the patient's serum magnesium concentration, possibly as a result of the suppression of early after depolarizations via calcium channel inhibition. For patients with recurrent torsade associated with bradycardia refractory to intravenous magnesium, overdrive pacing, or the use of isoproterenol may terminate torsade by increasing the heart rate and shortening the QT interval. In patients with long QT syndromes 2 and 3, mexilotine has been shown to shorten the QT interval. In patients without long QT syndrome, oral mexilotine may prevent the recurrence of torsade refractory to discontinuation of QT prolonging drugs, administration of intravenous magnesium, and correction of electrolyte abnormalities. I hope you found this video educational and useful. Please remember to like and share. Thank you.